Imagine stepping into a medical scenario where um, the only way to save your patient might actually mean actively risking the life of another person,
Yeah, that is a heavy thought.
right? And to make it even more complicated, these two people are sharing the exact same bloodstream. I mean, when you think about most medical specialties, the focus is usually squarely on one individual. You have one heart to monitor, one set of kidneys to balance. But obstetrics,
It's a whole different ballgame.
exactly.
Yeah.
Suddenly you are managing this incredibly complex, interconnected system where the biological needs of a mother and a developing fetus are constantly interacting. And, well, sometimes they're actively at war.
It really is the ultimate biological balancing act. You're monitoring a delicate physiological treaty between two distinct organisms, and the margin for error is razor thin.
So whether you are a medical student prepping for your boards, maybe a young professional stepping onto the wards for the first time, or just a lifelong learner fascinated by the extremes of human biology, welcome to this deep dive.
Today, we are looking at a stack of incredibly detailed source material. We're diving into the NMS Obstetrics and Gynecology 7th edition.
Oh, it is a phenomenal high-yield text. I mean, it covers the entire spectrum of women's reproductive health.
It is a massive spectrum.
It really is everything from the routine milestones of antepartum care to, catastrophic obstetric emergencies, gynecologic pathologies, and even the complex medical legal framework that governs how medicine is actually practiced.
So our mission today is to distill this massive volume into a clear, scientifically accurate audio guide. We really want to bridge that gap between the basic scientific principles you memorize and the real-world clinical applications you'll actually use when you have a patient sitting right in front of you.
And we'll even throw a clinical review exercise your way at the end to really lock in the concepts. Perfect. So, okay, let's unpack this. How does modern medicine actually manage this two-patient system?
Well, to manage it, you first have to understand what the baseline of peace looks like.
Right.
Before we can identify a pathology, we have to establish a rigorous surveillance protocol to monitor the developing pregnancy.
Yeah, and when I was reviewing the antepartum care timeline and the sources, it struck me as incredibly rigid. Like there are specific blood draws and ultrasounds tied to very specific weeks. It almost feels like we are constantly looking for a reason to intervene.
I get that, but really we are looking for early warning signs because when things go wrong in a pregnancy, they go wrong quickly. So let's look at the very first prenatal visit.
Okay, establishing the maternal baseline.
Right. We run a complete blood count, we check her blood type, and we run an infectious disease panel for things like rubella, syphilis, hepatitis B, and HIV.
I noticed the RH screen is a major focus right out of the gate. I know RH incompatibility is dangerous, but biologically speaking, what is actually happening between the mother and the fetus if their blood types clash?
So the mechanism is a classic immune response. If a mother is Rh negative, it means her red blood cells lack a specific protein called the Rh factor.
Okay, simple enough.
And if the father is Rh positive, the fetus might inherit that trait. Now, normally, maternal and fetal blood don't mix.
The placenta keeps them separate.
Exactly. But during delivery or even a minor trauma, some fetal blood can cross into the mother's circulation. Her immune system sees those Rh-positive cells as foreign invaders, almost like a virus, and it builds antibodies against them.
So the first baby is usually fine, but her immune system is now primed and waiting.
Precisely. If she gets pregnant again with another Rh-positive fetus, those maternal antibodies, specifically IgG antibodies, which are small enough to cross the placenta, they will enter the fetal bloodstream and systematically destroy the fetus's red blood cells.
Wow.
Yeah, it causes severe, sometimes fatal fetal anemia.
Which explains why the timeline dictates that at 24 to 28 weeks, an Rh-negative mother receives a shot of Rogam. But how does that medication actually stop the immune system?
Rogam is brilliant, honestly. It's essentially a dose of pre-made antibodies that bind to any stray fetal Rh-positive cells in the mother's bloodstream, effectively hiding them.
Oh, hiding them.
Yeah, it destroys those few stray cells before the mother's immune system even realizes they are there, preventing her from ever forming her own memory antibodies.
That is fascinating. It's like a stealth bomber for the immune system. Now, that same 24 to 28 week window is also when patients undergo the 1-hour glucose tolerance test for gestational diabetes. Why does this metabolic issue suddenly pop up right at the end of the second trimester?
It all comes down to placental hormones. As the placenta grows, it secretes large amounts of human placental lactogen.
Okay.
And the biological goal of this hormone is actually to make the mother slightly insulin resistant.
Wait, on purpose, on
On
purpose?
purpose, yeah. The placenta wants to keep more glucose circulating in the mother's blood so that there's a steady supply crossing over to feed the growing fetus.
So the placenta is intentionally hoarding sugar for the baby.
Exactly. But in some women, the pancreas just can't ramp up enough insulin production to overcome this induced resistance, and her blood sugar spikes to dangerous levels. That is gestational diabetes.
Going back a few weeks in the timeline, the 20-week mark is huge for genetic screening. The sources detail the quadruple screen for aneuploidy, specifically trisomy 21 or Down syndrome.
You're right, the quad screen.
And the text lists 4 markers: low maternal serum, alpha fetoprotein, low estriol, high HCG, and high inhibin A. Now, instead of just memorizing that list, what is the actual biological failure causing these specific shifts?
To understand that, you have to look at where these proteins actually come from. So alpha-fetoprotein, or MSAFP, is produced by the fetal liver.
Okay.
In a trisomy 21 pregnancy, fetal development is often delayed. That means the liver is immature and produces less MSAFP.
Got it. And what about the others?
Well, on the other hand, HCG and inhibin A are produced by the placenta. In Down syndrome, the placenta also fails to mature normally. It stays in this somewhat hyperactive, immature state, continuing to pump out elevated levels of HCG and inhibin long after they should have normally dropped.
So it's that specific combination, a lagging fetus and an immature placenta.
Exactly. That's what creates the signature chemical profile.
So the screen isn't just a random assortment of chemicals, it's a direct readout of organ maturity.
Yeah.
That makes so much more sense. But what happens when the pregnancy outlasts its biological timer? Like the textbook discusses post-term pregnancies past 42 weeks. I imagine the placenta wasn't designed to last forever.
It definitely has an expiration date. As we go past 42 weeks, the placenta begins to calcify and fail. It simply cannot transport enough oxygen and nutrients to sustain the massive, fully grown fetus. We call this placental insufficiency.
And to monitor for that, the text emphasizes the biophysical profile, and specifically the amniotic fluid index, or AFI. Why is the amount of fluid surrounding the baby the ultimate indicator of placental health?
Because the amniotic fluid is essentially fetal urine.
Really? Just urine?
Yeah. By the 3rd trimester, the baby is constantly swallowing fluid and peeing it back out. If the aging placenta starts to fail, the fetus experiences a drop in oxygen. As a survival mechanism, the fetal brain triggers a massive diversion of blood flow.
To protect the vital organs.
Right. It shunts blood away from non-essential organs like the kidneys and redirects it to protect the brain and the heart.
So less blood to the kidneys means less urine production.
Which means the fluid levels plummet. We call this oligohydramnios, an AFI of less than 5 centimeters. When you see that fluid drop, it is an ominous sign of chronic asphyxia.
Meaning the fetus is literally suffocating.
Yes, and it mandates an immediate delivery, often through induction.
And if we have to induce, the text mentions calculating a Bishop score. What does that actually tell us?
So the Bishop score evaluates how favorable the cervix is for labor based on dilation, effacement, and position. A score of 9 or greater means the cervix is soft and ready, so you can induce with pitocin.
And it's low.
If the score is 4 or less, the cervix is firm and closed. You have to use synthetic prostaglandins to chemically ripen it first, otherwise the induction will just fail.
Okay, so we've covered the routine maintenance and the aging system. Let's shift into the territory of sudden, catastrophic system failures. The sources highlight 2 massive 3rd trimester threats: bleeding and preeclampsia. Let's start with bleeding. The text contrasts placenta previa with abruptio placentae. How do these present clinically?
The presentation is all about where the blood is going and how the uterus reacts to it. In placenta previa, the placenta has implanted abnormally low in the uterus, entirely or partially covering the cervix.
Right.
As the pregnancy progresses and the lower uterus stretches, the delicate placental blood vessels tear. The hallmark here is sudden, bright red, painless bleeding.
Painless because the blood has a clear exit route out of the cervix. There's no pressure building up. What about an abruption?
Abruptio placentae is the premature separation of a normally implanted placenta. It rips away from the uterine wall before the baby is born. In this case, the blood pools and gets trapped behind the placenta.
So the blood is stuck.
Exactly. This hidden hematoma causes intense irritation to the uterine muscle. The classic presentation is agonizing abdominal pain, dark vaginal bleeding, and a hypertonic, rigid uterus that literally feels like a board.
And I imagine the baby is losing its oxygen supply simultaneously, right?
Yeah.
I saw the term late decelerations in the fetal heart rate monitoring section.
Yes, late decelerations mean the fetal heart rate drops after a contraction peaks and takes a long time to recover. It indicates the placenta is failing to provide enough oxygen reserve to handle the stress of the contraction. It's a massive red flag.
Now, here's a scenario that stood out in the reading as incredibly high stakes. Say a patient arrives at the ER at 36 weeks with third trimester bleeding. What is the absolute worst, most dangerous thing a clinician could do in that exact moment?
Oh, without a doubt. The cardinal rule of obstetrics is that you must never perform a blind digital cervical examination on a patient with third trimester bleeding until an ultrasound has definitively ruled out placenta previa.
Meaning, like, do not put your fingers into the cervix to check for dilation. Why is that so lethal?
Because if the patient has a previa, the placenta is sitting directly over that opening. Poking a finger blindly into the cervix could easily puncture right through the highly vascular placental tissue.
Oh, wow.
You could trigger a catastrophic hemorrhage that could drain the fetus's entire blood volume in minutes.
That is terrifying. So if an exam is absolutely unavoidable, how is it handled?
You perform what's called a double setup examination. You only do the pelvic exam in a fully prepped operating room with the anesthesiologist ready, the surgical team scrubbed, and the scalpel quite literally in hand.
So if you induce a hemorrhage, you perform a cesarean section in seconds.
Exactly. It's the ultimate safety net.
Now, the other major emergency is preeclampsia, which is characterized by new onset hypertension and protein in the urine. We talked earlier about the mother's immune system attacking the baby. Preeclampsia almost feels like the placenta attacking the mother.
You know, that's a highly accurate way to frame it. Preeclampsia is rooted in abnormal placental development. Because the placenta isn't getting enough blood flow, it becomes hypoxic. And in distress, it releases inflammatory proteins into the mother's bloodstream.
And those proteins cause the damage.
Right. They shred the lining of her blood vessels, causing them to leak fluid, which causes severe swelling and protein in her urine, and causing the vessels to clamp down, creating skyrocketing blood pressure.
And the only way to stop this inflammatory cascade is to remove the source of the proteins, delivery.
Delivery is the only definitive cure. If the patient is at 37 weeks, you deliver. But the clinical dilemma arises when a patient develops severe preeclampsia at, say, 32 weeks. The maternal environment is becoming toxic, but the fetal lungs are not ready for the outside world.
The sources mentioned using magnesium sulfate and corticosteroids to buy time here. Now, I want to clarify something. I thought magnesium was a smooth muscle relaxant used to stop preterm contractions. Why are we giving it to a patient with skyrocketing blood pressure?
It's a really common point of confusion. While magnesium does relax smooth muscle, its primary role in severe preeclampsia is actually as a neuroprotector for the mother.
Neuroprotector.
Yeah, those inflammatory proteins we mentioned, they're irritating her brain tissue, putting her at extreme risk for eclampsia, which is the onset of grand mal seizures. Magnesium sulfate depresses the central nervous system just enough to raise the seizure threshold and protect her brain.
So it's an anti-seizure safeguard. And while she is protected, you administer the corticosteroids. How do those help the premature baby?
Corticosteroids cross the placenta and act directly on the fetal lungs. They force the immature lungs to rapidly produce surfactant.
That's the soapy substance, right?
Yes, it coats the inside of the tiny air sacs, or alveoli. Without surfactant, a premature baby's lungs will stick together and collapse every time they exhale. The steroids basically give the infant a fighting chance at respiratory survival.
Okay, so we are managing this incredible, perilous balance. But let's transition away from pregnancy entirely. The sources also provide a deep dive into the non-pregnant reproductive system. We see how hormonal misfires and structural anomalies can completely derail the normal menstrual cycle.
Right. And to understand gynecologic pathology, we have to look at the mechanics of the normal menstrual cycle, which is divided into the follicular phase before ovulation and the luteal phase after.
The text notes that the follicular phase is highly variable from person to person, but the luteal phase is remarkably constant. It always lasts roughly 14 days. Why is that specific phase essentially a biological ticking clock?
It comes down to the lifespan of the corpus luteum. When an ovary releases an egg, the leftover follicle transforms into a temporary endocrine gland called the corpus luteum.
And its job is?
Its sole job is to pump out progesterone, which acts like molecular glue, stabilizing the thick uterine lining in preparation for a fertilized egg. But the corpus luteum has a strict biological lifespan of exactly 14 days.
So if there's no pregnancy,
If no pregnancy occurs, it abruptly dies. Progesterone levels crash, the glue dissolves, and the uterine lining sheds. That's a normal period.
which perfectly explains abnormal uterine bleeding. If a patient is anovulatory, meaning her ovaries failed to release an egg, what happens to that whole sequence?
It completely derails.
All right.
No egg means no corpus luteum. No corpus luteum means zero progesterone is produced.
So the lining never gets that stabilizing glue. It's just exposed to continuous estrogen from the ovaries.
Exactly. The estrogen causes the lining to grow thicker and thicker and thicker until it becomes structurally unstable. It outgrows its own blood supply and begins to slough off randomly in chunks.
Causing the bleeding.
Yes, this results in irregular, unpredictable, and often incredibly heavy bleeding.
And one of the most common drivers of this anovulation is polycystic ovary syndrome, or PCOS. The text emphasizes that PCOS isn't just a fertility issue, it's a systemic metabolic disorder. How does insulin resistance loop into all this hormonal chaos?
It's a vicious cycle. Patients with PCOS have severe cellular insulin resistance, meaning their pancreas has to pump out massive amounts of insulin just to manage normal blood sugar.
Okay.
And this excess insulin circulating in the blood acts directly on the ovaries, overstimulating them to produce excess androgens, like testosterone.
And high testosterone halts the development of the follicles.
Right.
Right, stopping ovulation entirely.
Right, so you end up with hyperandrogenism causing acne and excess hair growth, along with irregular menses and a very high risk of developing type 2 diabetes.
Because of the root metabolic cause.
Exactly. Because the root cause is metabolic, the first-line treatment is often weight loss and metformin to improve insulin sensitivity. We also use continuous oral contraceptive pills to force a regular bleeding cycle and suppress that ovarian testosterone production.
So PCOS is a failure of the chemical messengers. Let's look at a structural failure. How does endometriosis compare to something like uterine leiomyomas or fibroids?
Well, they are structurally very different. Endometriosis occurs when endometrial tissue, the cells that normally line the inside of the uterus, somehow implant outside the uterus. They can attach to the ovaries, the fallopian tubes, or even the pelvic sidewall.
And because they're endometrial cells, they still listen to the hormones. They grow and bleed every single month.
Right, but unlike a normal period, this blood has no anatomical exit. It gets trapped inside the pelvic cavity, causing massive chronic inflammation, intense cyclic pain, and deep dyspareunia, which is pain during intercourse.
Wow. And fibroids, on the other hand, are a completely different tissue.
Correct. Leiomyomas or fibroids are benign, smooth muscle tumors growing directly within the muscular wall of the uterus. They don't typically cause the intense inflammatory pain of endometriosis.
What do they do?
Their sheer physical bulk distorts the uterine cavity, leading to incredibly heavy menstrual bleeding and a constant sensation of pelvic pressure.
If a patient comes to you with chronic pelvic pain, I'd imagine the instinct is to immediately look inside and see what's wrong. But the text advocates a stepped approach. How do you decide between medical management and jumping to a surgery like a laparoscopy?
The clinical philosophy is to always attempt to quiet the system down medically first. You start empirically with NSAIDs, like ibuprofen.
Just over-the-counter stuff.
Yeah, because NSAIDs directly inhibit the production of prostaglandins, the chemicals that cause severe uterine cramping. You combine that with continuous oral contraceptives to completely shut down ovarian function. By stopping ovulation, you stop the hormonal fluctuations feeding the bane.
You essentially put the cycle to sleep.
Yes. Surgery, such as a diagnostic laparoscopy to visualize and burn away endometriosis, is strictly reserved for when a patient's pain is completely unresponsive to that medical suppression.
Are there any exceptions to that rule?
The one major exception is if an ultrasound reveals a complex adnexal mass, a lump on the ovary or fallopian tube, like an endometrioma or potential tumor. That must be surgically evaluated to rule out malignancy.
That makes perfect sense. Now, grasping all this clinical knowledge is vital, but it's really only half the job. The other half is applying that knowledge safely within the bounds of the law. Let's explore the medical legal landscape of obstetrics and gynecology.
Yeah, OBGYN is one of the most highly scrutinized fields in medicine because it inherently deals with the origins of life, congenital defects, and high-stakes surgeries. The textbook breaks down the absolute bedrock of medical malpractice, which is the legal definition of negligence.
The sources outlined 4 specific pillars that must be proven sequentially. Let's walk through a scenario instead of just listing them. How does a lawyer prove a doctor was legally negligent?
Okay, let's use a hypothetical. First, a duty must exist. The moment a patient schedules an appointment and you agree to treat them, a physician-patient relationship is established. Second, there must be a breach of that duty. This means the physician failed to provide the recognized standard of care.
Like missing a routine test.
Exactly. Imagine a doctor simply forgets to offer the quadruple genetic screen we discussed earlier.
Okay, so the doctor made a clear mistake. Is that malpractice?
Not automatically, because you need the third and fourth pillars.
Yeah.
Causation and damages. Let's say the doctor forgot the test, but the patient goes on to deliver a perfectly healthy baby.
There was a breach, but no harm occurred.
Therefore, no legal negligence. Malpractice only exists if that breach directly caused real, quantifiable physical or emotional damages to the patient.
That distinction is crucial. Now, the text also delves into some highly specific, deeply complex legal actions unique to obstetrics wrongful birth versus wrongful lice. These sound identical to a layperson, but legally they are worlds apart.
They represent very different legal arguments. Wrongful birth is a lawsuit brought by the parents. They argue that because of a physician's negligence, perhaps failing to offer cystic fibrosis screening or misinterpreting an ultrasound, a severe congenital defect was missed. The core legal argument is that the physician's error robbed the parents of their right to make an informed decision about whether to legally terminate the pregnancy. These cases can be successful because the parents face immense, quantifiable financial burdens for lifelong medical care.
And wrongful life is brought by the child.
Yes, brought on behalf of the impaired child, essentially arguing that because of their severe defects, it would have been better had they never been born at all. The courts almost universally reject wrongful life claims. The legal system simply cannot quantify the value of an impaired existence versus non-existence.
For the medical students or professionals listening, what is the ultimate takeaway here? How do you insulate your practice while still providing excellent care?
The absolute strongest shield you have is the practice of rigorous informed consent and meticulous documentation. It is never your job to force a test on a patient. Your duty is to ensure they understand their risks, the limitations of the screenings being offered, and the options available to them. Documenting that you had that comprehensive conversation and recording the patient's autonomous choices is how you practice medicine that is ethical, safe, and legally sound.
That is a powerful summary. Let's recap the journey we've taken today. We started by decoding the strict preventative timelines of antepartum care, understanding how maternal antibodies and placental hormones dictate our testing.
Yeah, that baseline is everything.
Then we explored the mechanisms behind catastrophic emergencies, contrasting the painless bleeding of placenta previa with the hidden trauma of an abruption, and unpacking the inflammatory storm of preeclampsia. We transitioned to the non-pregnant system, tracking how the 14-day clock of the corpus luteum regulates the cycle, and how insulin resistance fuels the chaos of PCOS. And finally, we grounded it all in the 4 pillars of medical legal negligence.
It is a massive amount of interlocking information. But when you move beyond rote memorization and understand the why behind the symptoms, the clinical protocols really just write themselves.
Well, to put that to the test, let's put you, the listener, on the spot with a clinical review exercise. Here is the vignette. You are evaluating a 28-year-old female presenting to the ER with sudden onset, right lower quadrant pain and spotting.
Okay, classic presentation so far.
Her last menstrual period was exactly 6 weeks ago. Her quantitative HCG blood test comes back highly elevated at 2,553 MIU/mL. You order a transvaginal ultrasound. It reveals a 2-centimeter complex mass in the right adnexa, but her uterus is completely empty. What is the most likely diagnosis, and what is the primary medical treatment if her blood pressure and heart rate remain perfectly stable?
Let's break down the clues. She has a positive pregnancy hormone test, but an empty uterus. The pain and the mass in the adnexa, the area next to the uterus, point to a pregnancy that has implanted in the fallopian tube. The diagnosis is an ectopic pregnancy.
And for treatment?
Because she is hemodynamically stable and the mass is small, we want to avoid surgery. So the medical treatment of choice is methotrexate, a drug that halts the growth of rapidly dividing cells, allowing the body to safely reabsorb the ectopic tissue.
Spot on. To leave you with a final provocative thought today, we spent this entire deep dive talking about the mother as the primary patient, monitoring her system to indirectly preserve the fetus. But consider the rapidly evolving field of in utero fetal surgery. Surgeons are now opening the uterus to operate directly on the fetus to repair congenital defects like spina bifida before birth.
It's incredible technology.
It really is. But in these scenarios, the fetus physically becomes the primary surgical patient. As this technology advances, how might it fundamentally alter our current medical legal definitions of duty, patient rights, and the balance of risk? Keep studying, keep asking the hard questions, and keep diving deep.